Hello, everybody.
A long time.
Hello, everybody. Welcome back to the Incubator booth at NeoHeart 2024. We are joined this afternoon with Dr. Usha Krishnan. Usha, thank you for making the time. And Amara Majeed, thank you, Amara, for joining us. Your emotional support for Usha. That's what you told us.
Yes, I am.
Okay, very good. Usha, I wanted to maybe start with you and mention to the audience that you were part of a few sessions, but you had a presentation called Critical Choices to Close or Not to Close Shunts in Neonates with BPD.
Yes.
So yes or no?
Yes.
Can you tell us a little bit what are some of the takeaways from the presentation for the folks who didn't have the opportunity to be here at this conference?
So, first of all, hello, everyone. And you guys really missed something by not coming in here in person. Right? It's been a fabulous conference. And some of the takeaway points on at least that the first session that I presented in were that it takes a village to take care of these patients, and the decision is never individual. You have to take into account a lot of aspects of your patient and the family and the physiology before deciding on the right path to take for every patient. So the decision to close or not close a shunt is not just because the shunt is there, but if the shunt is there, what is its impact? And if you close it, it should not be detrimental to the child.
And can you tell us, so what are those things we should be looking for to make a decision? Is the shunt affecting the baby with BPD?
So if there is evidence of left-sided volume overload, and if there's evidence of increasing respiratory needs for the baby, then closing a shunt will be useful. But at the same time, you have to make sure that the shunt is entirely left to right and the shunt is not acting as a pop-off or something which will make the baby worse if it's closed.
Amara, I want to turn to you. I know you're only here for emotional support, but you are also a pediatric cardiologist, and you're both coming to us from Columbia, obviously, so up the road. Can you tell us a little bit why you enjoy this conference as a pediatric cardiologist? Why is it important for you to interact with the neonatology world?
Yeah, absolutely. So I'm an imager. I do all sorts of imaging modalities, which includes fetal, transthoracic, as well as cross-sectional. And I think for me, and I know you asked one of the sessions that was, we just came from it, is the talk on the borderline left ventricle that we just heard. And I think for me, it's a very interesting journey because we see these patients, I see them from the fetal standpoint all the way up into my clinic. And I think it was very enlightening for me to see all these experts, come together and really talk about how it's a moving target at each point. And as a fetal cardiologist, counseling these patients becomes very, very important. And so, I think for me that was one of the biggest, one of the most exciting sessions of this conference.
It's so interesting because as pediatric cardiologists, your role is constantly expanding. Initially, it was you're just like taking care of cardiac disease in the pediatric population. And then it's sort of like adults growing with congenital heart disease. So now you're taking care of much older patient. And now you're saying the needle is moving also backwards where even prenatally, we're going to start getting involved. This is something we've heard from other speakers and other attendees. And everybody seems very happy about this more global approach. Can you tell us, from a workload standpoint, it's more work. So you would expect people to be like, oh my God, like this is getting too hard. But no, everybody's very excited about that continuum. Can you tell us why that is?
Yeah, I think pediatric cardiology is fascinating because, and actually this is interesting because when I first joined Columbia, this was my talk, and it's really across the lifespan, what we talk about, outcomes across the lifespan. And that really does start in fetal life. And, we heard talks about neurodevelopment yesterday. And so all of these things, you start talking about your patient from when they're in utero. And, there's a lot of research, of course, coming out that stressors in utero can also impact outcomes. And so the pediatric cardiology, it's really not pediatric. It's not pediatric, really.
Human cardiology.
It is human cardiology, and it evolves across the lifespan. And I think the concept of lifespan research, is something that everyone is moving towards. And so what you do today what will that do 20 years later? I think that's the global picture. And I think a lot of talks here have highlighted that.
Very cool.
Absolutely. And then in the spirit of collaboration, which is really the underlying theme here at NeoHeart, what is the best way, tips for neonatologists to interact with our pediatric cardiology colleagues?
So I'm a pediatric cardiologist, but I think I spend majority of my time in the NICU. So most neonatologists, I think, have taken me into their clan.
You've been accepted into pride.
I've been accepted into the neonatology community. So I think it's just good collaboration, mutual respect, and understanding each other's expertise and respecting that. That is the most important thing.
You were part also something that we've talked about with other guests relates to pulmonary hypertension. And can you tell us a little bit how that in your institution, especially with such a specialized focus and neonatal cardiac teams, how has your approach changed specifically in terms of managing pulmonary hypertension?
So our institution is one of the largest pulmonary hypertension centers in the country, probably in the world. And we are unique in certain ways. We take care of patients of all age groups, including adults.
I see.
So it's peds and adults, which is somewhat unique. And my focus is on pediatric pulmonary hypertension, but 50% of that is in the NICU, which is why I spend so much time in the NICU. So people sometimes tend to think about the heart as only the left heart or only a single ventricle. But I'm the advocate and champion for the right heart.
Right.
And that's where pulmonary hypertension resides.
What are some of the lessons you're learning from the management of your patients with PH in the adult population that you are translating back to the neonates? Some things that you're learning as in that particular age group. I think that would be interesting.
So the medications we use in adults are the same medications we use in children, but a child is not a tiny adult. So we have to think about all the physiology and the uniqueness that goes with different age groups while we start medications. And so one has to be very judicious.
And is there anything that you're taking from the NICU management to the adults that has evolved over time?
Just be nice and gentle to everyone.
Right. Now, are adults big children? Is that, can we see that? Yeah.
Very often, most of the time.
Thank you guys so much for taking the time to drop by and sharing some of your thoughts with us on the podcast.
Thank
Yeah,
you
thank
so
you.
much.
Thank you.
Bye.